Ready?
Can we start? Okay.
Okay, Klaus, your stage. Thanks
Talking
for
about
coming.
athletes, we're going to talk about the throw shoulder. I of course have to thank Manas and Manas very much for a new invitation. It's a great honor to be here. This is not working. So I'm going to talk about the throw shoulder. I think we have to talk about the etiology. The typical thrower, at least in America, is baseball pitchers. They have a very high speed during throwing, about 7,500 degrees per second. They don't have that many repetitions during the season. It's all overhead. You have racket players. I think they belong to the thrower shoulder group as well. They also have high speed, but not all repetitions are overhead. Then we have handball players. Denmark, I think, is a very good nation of handball. They have medium to high speed throwing, more repetition and many tackles, so they get a little bit of trauma as well. And then I have to mention the swimmers as well, because they are overhead athletes. They have numerous repetitions, up to 1 million per year, but with a much lower speed, like 60 degrees per second. So what happens maybe with the etiology of the thrower shoulder is that the many repetitions may cause them overuse and fatigue, whereas the throwers, they have both the fatigue and traumatic lesions. I think the link between etiology and pathology is the most important issue in the overhead athlete's shoulder. Maybe some of you know the novel House of God by Samuel Shem. It's said there that the first thing to do at a cardiac arrest is to take your own pulse. We know that as old doctors. The thrower shoulder, I think we transcribe it to the first thing to do in a thrower shoulder is to look at the kinetic chain. And I think I can address this to Ben Kibler and Giovanni Diacomo, who has been describing this a lot of time. So I always ask my throwers when they have pain, how much of the force of the throwing actually comes from the shoulder, and they always say 60 or 70%, and it's only 18% in many studies. This is just a case. As a Danish tennis player, she used to be number 1 and also number 3 in the world. She gave up during the French Open due to back pain. 10 days after, it was said in the media that she was fully rehabilitated. She returned to play, and 4 weeks later, she developed shoulder pain. I saw her for a clinical examination, and everything was normal, stable scapulothoracic motion, a negative provocation test. I convinced the coach and the player that an MRI was not necessary. I was afraid that she had a lot of pathology. I'll return to that later. The thing was that she had an unstable core, that she still had a spine problem, and after spine rehab, she returned to play without shoulder pain. So I think we should address the kinetic chain when we see throwers with shoulder pain. So the thrower shoulder is a shoulder at risk. The capsule has numerous repetitions in external rotation and abduction, the same position. We all have this normal laxity. The throwers want more external rotation. Then they get what we call hyperlaxity, which is normal. It can become unstable. Then you have a problem. And also they have decreased internal rotation, which you all know known as GERD. And this changes the center of rotation, and this further pushes the capsule and the labrum. And then we have to think about the scapula and rotator cuff with the fatigue, and you get repeated minor or major trauma. This was already described many years ago by Burkhardt, Kibler, and Morgan, that you have a muscle imbalance of the cuff and the scapula. You have contracture of the posterior capsule and the cuff. So you end up with the GERD, and then you get slap lesions and superior instability. And with all these changes in the joint, you get the CAM effect and the anterior pseudolaxity. And they also told us to be aware of the dysfunctions of the kinetic chain. This is a video from Kibler. How do I, can I act in there? Okay. Is it running? I hope my videos are running. Yeah. This was a 19-year-old baseball pitcher, actually referred to an acromioplasty, which I think most of us would not do. After one repetition, this very skilled baseball pitcher, he already has a severe scapular dyskinesis. Of course, an acromioplasty would not help this guy. Ben Kibler also here shows his scapular retraction test. He starts out with the abduction test. You cannot see it, but the player says he has pain on the lateral aspect of the shoulder. I think sometimes when you make this test, the patients are actually weak, and then he retracts the scapula and makes the same test, and it's a very good experience for the player that he actually becomes stronger and pain-free. This is an unpublished study, but it's just to remind us that the scapula plays a role. I just tested the Danish national team swimmers in 1993. They were all competing, and still 38% had shoulder pain, 67% had shoulder pain history, 57% had a positive Hawkins test, and this was when I actually the first time was aware of the scapular humeral motion. 95% had abnormal motion, despite they were normal functioning swimmers. So this has been shown in many studies that scapular dyskinesis is strongly associated with shoulder pain in overhead athletes, and we should be aware of this. So we made this study, 78 pain-free swimmers, very difficult to find pain-free swimmers. We tested them 4 times during a training session, took them out of the water, measured the scaption, and what we saw was that from beginning, 0% had scapular dyskinesis. It just accumulated for every test, ending up with 82% scapular dyskinesis at the end of the training session. This was pain-free normal swimmers. So when we look at the overhead athletes, we have to look at the pathology as well as the dysfunction. You can see different kind of labral lesions. You can have attenuated and redundant capsule. You can have slab tears, glenoid erosion, maybe pasta. But then again, we have to think, is this pathology or is it adaptation? Because we see the same changes in those patients that are symptom-free. And Knut, who's also here, showed already in 2012 that you see this in young javelin and volleyball athletes, that they get these pathological changes in relation to the insertion of the posterior rotator cuff. I think this is one of the best studies showing that MRI may not reveal the whole truth. 93% of throwing shoulders in this study had a normal MRI findings. Only 37% were symptomatic, and it was mainly partial rotator cuff tears and osteochondral defects of the humeral head. And they found that the symptoms correlated poorly with abnormalities seen on the MRI and the clinical findings. In my practice, I tend to divide the problem into 4 categories. You have lateral shoulder pain syndrome, then you have the posterior superimpingement, and then you have the anterior superimpingement, and the last group is the anterior minor instability. Probably, there are some studies now showing it has the same etiology, so it's overuse leading to fatigue of mainly the scapular stabilizers, leading to scapular dyskinesis, microinstability, with or without GERD, and also kinetic chain dysfunction. So many of the etiological factors are the same in these 4 categories. Castagna described this in 2010, that the etiology of the PSI syndrome is unclear, but it includes anterior shoulder instability or microinstability, contracture of the capsule posteriorly, and reduced humeral retroversion and scapular dyskinesis. The etiology of the anterior minor instability is the over-rotation during throwing increases the stress of the anterior capsule and during the late cocking phase, whereas the posterior capsule is widened and traumatized during the deceleration phase. The consequence is microinstability, which corresponds in posterior capsular hypertrophy, leading to increased external rotation and a reduced internal rotation. So clinical findings in the lateral shoulder pain syndrome is like impingement with positive scapular test, positive Hawkins and Jobe test. On the imaging, you can see bursitis, tendinopathy. In advanced stages, you can see pasta lesions and rarely labral pathology. Whereas the posterior superimpingement, you have also positive scapular test, dynamic shear test, all the labral test, and positive GERD. And on pathology, you can see posterior superior labrum fraying with or without avulsion, and possibly here also a pasta lesion. The clinical findings in the anterior superimpingement is again scapular dyskinesis, probably pushing the humeral head forward, so you create like a biceps tendinitis with anterior pain. You get positive biceps tests, and the imaging shows slab lesions, long head of biceps pathology, maybe a Buford complex. The last group, the anterior minor instability, you have instability test positive, sulcocine apprehension test, scapular dyskinesis, and on imaging you see labrum pathology. They can be slab Purtis lesion, attenuated capsule, or even Hagel lesions. So in all these thrower shoulders where you don't have any trauma involved, I think the non-operative treatment, of course, is the first thing to do. The main goal is to relieve pain and reestablish biomechanics. So the physiotherapy should address scapular and kinetic chain dysfunctions, concentrate on the rotator cuff, also do some stretching, sleeper stretch if there is GERD involved. And maybe it's controversial, but if pain prevents effective physiotherapy, a cortisone injection can relieve pain and guide and let the thrower come a little bit faster to recovery. And of course, as I mentioned, you have to manage the kinetic chain dysfunction. This is described by Cools and also Stone. I'm not a physiotherapist. I leave this to the physiotherapist to analyze for inflexibilities of the hamstrings and hip and trunk, and of course of the core weakness as well. So this should be addressed in the throwers. So when we come to operation at a surgery in these throwers, if you have a lateral shoulder pain syndrome, it's very rarely indicated, maybe only with a progression to a large pasta lesion. In a posterior supine impingement group, you can have labral repair, biceps tenodesis, or maybe just a debridement. The same you see with the anterior supine impingement. And then the anterior minor instability, maybe just a minor anterior stabilization with or without a biceps tenodesis. So in summary about the etiology and clinical presentations, the majority of throwers with painful shoulders it may be caused by disturbances of the kinetic chain and primary fatigue of the scapular stabilizers. The clinical presentations and radiological findings may differ with pain location and corresponding structural pathology. I think the treatment primarily should be directed towards the etiology, and if this fails, surgery can be made to correct pathology. We have to talk about slap tears or peel back lesions. The results are not very encouraging, either for non-operative and operative treatment. You have a low success rate and high revision rate, especially in throwers, which showed by Yang that if you have participation in overhead activities, the prognosis was worse. So I haven't been doing a slap repair for many years now. I prefer biceps tenodesis, and some of these things support this, because in some cases of slap repair, you may have a poor outcome due to persistent pain. And we are talking about throwers. They cannot have pain. They cannot have restricted motion. Maybe because of a too tight repair, maybe poor healing capacity, and it's also known that you can have hardware complications. So it's known that success rate in overhead athletes after slap repair is very low, with a risk of permanently reduced external rotation, stiffness, and pain, and this is not, it's a no-go for a thrower. And newer studies now shows that suprapectoral or subpectoral tenodesis results in faster and higher return to sports and rarely affects the external rotation. This is a systematic review and a meta-analysis showing that biceps tenodesis result in a significant higher patient satisfaction and significantly higher return to sports rate. This is an example of a 16-year-old handball player, 4 months of shoulder pain after a traction injury during a match. She had a subluxing sensation. She presented with pain and restricted motion. She had not been able to throw for 4 months. She was, I had to activate this just a minute.
Again.
This is her flexion. It looks very good, and you can see that she was taught about the scapula. So this is very good flexion, but when she puts the arm in the throwing position, this is the active motion she can actually tolerate. So this is not a good thing for her. She was told to rest in rehab for 1 year. The MRA showed discrete findings. She had physiotherapy for 4 months without any progression, so the conclusion was that she had an anterior minor instability and a superior labral tear. So the goal of the treatment was to reduce the hyperlaxity and to release the painful biceps. So I performed an arthroscopic minor anterior plication and biceps tenodesis. And this is the findings. Arthroscopically, you see it's very discrete. She has a little bit of a drive-through sign. It's not in this video, but the upper labrum was looking perfectly normal, but she had so much biceps pain. So we went on with the procedure. So she had minor anterior plication and biceps tenodesis. I just put in 1 stitch and 1 anchor around the horizontal plane. You see it in a moment here, and then the anchor is coming in now. Just a single anchor here, just a small plication, reducing the anterior capsule width. Just a minute. And then I turned to the front of the shoulder and made a biceps tenodesis. I use a suprapectoral biceps tenodesis. I put the tendon in the drill hole and then fix it with an absorbable screw. So this is her 4 months after the has a full acceleration motion, more than 90 degrees, a very satisfactory result. This is from her rehab, just to show the physios are doing very well work. She was very happy about the result already 4 months after she could return to handball. I just operated on a 17-year-old handball player. She had a different etiology because she also fell on the shoulder. She's number 20. Oh, sorry. Number 20, receiving the ball now, puts the arm in the throwing position, but he also lands in the throwing position, which is not very good for the shoulder. So she had no progression in the symptoms. She had still symptoms, so this is her MRA showing slap tear and also slight anterior labral tear. This is her intraoperative picture. She has a big slap 3 tear with an interpositioned flap. This is her. This is the big flap from the slap 3, which of course gives her a lot of mechanical problems. Then she has this. It's only a minor anterior labral avulsion, but it's unstable, as you see here. So I just remove the little flap and then put in 2 anchors here past the suture to bring the labrum back. I can just skip a little of this. So here comes the first anchor, so bringing the labrum up again. So in this case, a real avulsion. This is another handball, just to show that you can have labral tears anywhere. This is a slap tear and a posterior inferior tear, also with impingement like a flap tear. Of course, this is creating some problems. And here again, a biceps tenodesis showing that you release the retinaculum here to have the long head of the biceps slide free, so you can put it in the groove with a screw. So I just skip the next one. Sorry. So the characteristics of the handballer shoulder with minor instability, that they have no Hill-Sachs lesion. They have anterior, superior, maybe also posterior labrum tears. Pastel lesions are rarely seen, except if they have been a little bit older than the ones I showed you. They have active range of motion is affected. They are unable to throw, and they have pain and dead arm sensation. This is a patient 4 months after this procedure. She's right-handed. She has a full flexion, full abduction, even behind the horizontal plane. She has a full external rotation and motion. She has a little bit of a girth still. She has good strength. She has negative O'Brien. I'm doing an apprehension test on her now. She has no problems. I asked her to shake her head. So she's very happy already at 4 months. Till now, the last 4 years, I performed 18 operations on 18 players. And 3 were even revisions after previous banker repair. 17 out of 18 returned to play at 4 months and returned to game after 5.5 months. There was one complication with adhesive capsulitis. She had additional surgery and she had a prolonged rehab. So take-home messages about the thrower shoulder. It covers a wide variety of pathologies and dysfunctions of the kinetic chain, the glenohumeral joint, and the scapulothoracic articulation. The transition between pathology and adaptive changes is unclear. The treatment target may lie in the analysis of etiology in combination with pathologic findings, because we have to think of this as an overuse injury mostly. Non-operative treatment should address the dysfunctions of the scapula and the kinetic chain, restore normal shoulder kinematics, and operative treatment may be indicated after 6 months of treatment without progression. In throwers, both non-operative treatment and operative treatment generally has a lower success rate with regard to return to play. Biceps tenodesis seem to have a significant better outcome than slap repair in throwers, and capsulorrhaphy of recurring minor instability with sparse macroscopic finding reveals good results. And we have some connections between Denmark and Greece with the Queen Anne-Marie and Constantine, and also my favorite captain of my football team, Carlos Seger, who is from Greece. Thank you very much.
Thanks, Klaus, for this excellent keynote lecture. Really very, very interesting. I agree on the throwing shoulder. It should be more the throwing body, I think, thrower's body. Is there any question from the audience? No, I don't think so. So I have a question for you. Do you always do an MRA, so with the arthrogram in the throw shoulder?
I always do it if they have a traumatic incident. Like I see a lot of handball players, so they both have the overuse, and then they have some minor trauma, like a girl on the video. So in that case, I think it's indicated. But also in the case with the tennis player, sometimes you don't need it, because if you find deficiencies of the kinetic chain, the MRI will not give you anything more than worries, because you have to explain her daddy is the coach. You have to explain she has a past lesion, she has a labral tear, but the solution lies somewhere else. It's sometimes difficult to explain.
Thank you very much for your talk. I'd like to ask you something, because I was recently in a meeting, and there was a round table about modern indications of the use of PRP. And I copied some slides about the possible options, no-go zones, and the best indications. So in the no-go zones was the shoulder indications.
It was a no-go.
Yes.
Okay.
I can tell you, because it's easy for me, 3 best indications for PRP, 2 possible options, no-go zones, future horizons. And 3 best indications for PRP: elbow tendinopathy, gluteal tendinopathy, and knee osteoarthritis. 2 possible options: patellar tendinopathy, insertional Achilles tendinopathy, and no-go zones: full or near full thickness tears, unrealistic patients' expectations, and shoulder indications. So, do you use any PRP in shoulder?
I don't use PRP.
Because I saw that you do the classical and the normal, in my opinion, injection of cortisone.
I have no experience
necessary.
of using PRP in the shoulder. We have 2 doctors at the hospital that does that, but not in the shoulder. Maybe it's because it's too complicated. I don't know, as I don't have any experience, probably for conditions where you have degeneration. And of course you see degeneration in these young, but it's not one single thing. I don't have any experience of getting them pain-free by that. I know that cortisone, you should not administer too often in these young patients, but it's very effective for pain killing, and then the physiotherapist has much better conditions.
So regarding PRP, maybe I can jump in. I'm the president of the shoulder and elbow expert group in Switzerland, and we just had this week, we talked about this, and we looked at the literature that is currently out there for rotator cuff and for elbow. And for rotator cuff, there is mixed evidence, but in the end, we don't recommend it to the Swiss government to use it. We recommend it, however, for the elbow. So I do also PRP injections, but less and less, to be honest.
I was planning to ask Klaus a question. I'll ask him. But first, for the PRP, the problem with the PRP that every composition of PRP is different, and so many compositions, so you can't make anything from the data in the literature. I use PRP. I use specific one with a specific indication, and so far we see very good results for specific indications. It's not the topic of so I'm not going to go into it. We can talk about it later. But Klaus, excellent keynote lecture. One thing that I see, and I think was maybe missed in your lecture, and I see patients that come to see me after they've seen another surgeon throwing shoulders. They will send for MRI, and there is a query slap lesion, and the surgeon wants to take them to repair the slap or to do a biceps. And the only thing that they have is a bit of tear of the AC joint disc. And you give injection to the AC joint, and surprise, surprise, they're healed. So it is just to raise the awareness that the AC joint can be another problem in a throwing shoulder, which is easy to treat, and don't take the MRI slap or query slap as the cause for that.
I completely agree. I think we are agreeing on the clinical approach that you should look for the symptom location. So, and that's the problem with the throwers. They have so much pathology in the shoulder. So you should direct the treatment towards that, or avoiding more progression.
Klaus, here, just one more question. Thanks for the really nice talk again, like as always. Do you have any advice for risk reduction, prevention strategies? You see so many athletes when it's, you know, that little bit of too late. So do you have any advice that you could give for, you know, people that take care of athletes to maybe watch that kind of steps they should not, you know, pass, so you don't cause that severe injury?
I don't have that much contact with the clubs anymore, but I have realized that they have an increasing understanding about the kinetic chain. Maybe they don't call it that, but core strength and flexibility. I think it's they use most of their training outside the playing field, strengthening their core and getting flexible enough. So I think there's an awareness of it, but I have to return to handball all the time. It's a risk sport, so you have to be putting your shoulder at risk to be the best one. So it's very difficult to prevent that, I think.
Klaus, thanks a lot for your excellent talk again. I think we need to move on to the next session. So it's about shoulder courses, the past, the present, and the future.